Everyone, pursue what catches your heart, not what catches your eyes. A very warm welcome to everyone to the Woodlands Annual Cardiac Update. We are proud to host this grand evening. We all know the importance of knowledge sharing in healthcare, and Woodlands has been playing a pioneering role on that front through its CMEs, like the one we are hosting this evening on cardiology. We had a successful surgical update, and now it's time for the cardiology update. I am Dr. Shoptoshi Basu, the Medical Superintendent of Woodlands Multi-Speciality Hospital Limited, your MC and moderator of the sessions for the evening. Our expert speakers will be deliberating on some very topical subjects today: heart failure, medical therapy optimization, and device therapy, in which Dr. Shunil Boron Roy, Director, Interventional Cardiology, Dr. Sharoj Mondol, Chief Senior Consultant, Interventional Cardiology, Dr. Imran Ahmed Siddiqui, Consultant, Interventional Cardiologist, Dr. Hema Malathi Rath, Consultant, Interventional Cardiologist, will be participating. This will be followed by a very interesting topic, that is artificial intelligence in coronary artery disease, with Dr. Abhishek Shaha, Consultant Interventional Cardiologist, and Dr. Chonchol Kumar Kundu, Consultant Interventional Cardiologist. We would also like to mention our sponsors for their support: Boston, Lupin, Pristine, and AdHealth. A big thank you to all of you. Without further ado, and let us get the evening rolling with the ceremonial lamp lighting, may I invite on stage all the speakers, with Dr. Rupali Basu, Managing Director and CEO of Woodlands Multi-Speciality Hospital, Dr. Malti Purkait, Chief Operating Hospital, Woodlands Multi-Speciality Hospital. Please, madam, all the consultants, please.
गणनायकाय गणदैवताय गणाध्यक्षाय धीमहि गुणशरीराय गुणमण्डिताय गुणेशानाय धीमहि गुणातीताय गुणाधीशाय गुणप्रविष्टाय धीमहि एकदन्ताय वक्रतुण्डाय गौरीतनयाय धीमहि गजेशानाय भालचन्द्राय श्रीगणेशाय धीमहि एकदन्ताय वक्रतुण्डाय गौरीतनयाय धीमहि गजेशानाय भालचन्द्राय श्रीगणेशाय धीमहि.
Thank you, everyone. Request everyone to please take your seats. And as I call upon our Managing Director and CEO, Dr. Rupali Basu, to say a few words.
Good evening, everyone. A very warm welcome from Woodlands Hospital, from all of us, to each one of you for gracing today's CME on a Sunday evening. Our social calendars are busy, I know, so it's an effort to be here and listen to the updates, innovations of cardiology from our very senior consultants. How do I say? I just need to get my phone. Can I get my phone? I'll just have some quotes to say to all of you, just to say. For me, the journey starts with excellence. If there's a word which is to be used for tonight or today evening, it is excellence. There are some quotes which I was looking through. Excellence is a gradual result of always striving to be better. This is one. Someone said that perfection is not attainable, but if we chase perfection, then we can catch excellence. The pursuit of excellence with unrestrained passion can lead to the accomplishment of wonders with unsurpassed joy. Excellence is a continuous process and not an accident, our past president said. Excellence is doing ordinary things extraordinarily well. And I think I like the last. We are doing everyday work, but if we do our job better, more better, every day, whatever we do can be done better way. And we know that that is how the standards, high standards come, and that is how the excellence happens. And Woodlands is actually on that journey. It started years back before our independence in 1946, as you all know. This is our 77th year, more than before Indian independence, and the organization has grown so much, but still there is so much to do. And that is what we are on, our journey is on. That is what we are going to do. You all know how we have halved the size of the hospital, the department sizes, everything has come down now. We have demolished a major portion, more than half the hospital. And we are going to bring up a new block, try to bring in all the specialities which we didn't have so far, like oncology. And then, move to this transformational journey of what we were and what we will become. Or, as I say, it is rather an excellence journey. We were doing well, but we have to keep doing even better and even better. And that is the journey that we are on. I think the CMEs are one of many, many activities are happening in many ways. CMEs are one which we thought that we should start doing now. Because once our big hospital happens, there will be, every day there should be one educational talk by any one of our consultants. We have 796, I think close to 800 doctors with us. Fortunate to have that in Woodlands Hospital. In my last hospital, I keep saying, I had 800 beds and 200 doctors. Here we have 200 beds and 800 doctors. So each one of you actually can take up your choice of subject, become the organizing chairperson, and start organizing CMEs, because those are very, very important to do. The science is moving, it's dynamic, and we have to catch on to all the new things that's happening. Even the old things that we do need to be discussed again and again. And CMEs should be our way to do things at Woodlands. And we have started, I think we started doing surgical update. We have done one more. Or the first one was surgical, or we did one more? Which one we did, Shaptoshi?
It was a surgical update, madam.
Surgical update. So we started with surgical. Today we are doing cardiology. I think next month we will do oncology, and we'll go on doing that. And then we can go to the subspecialties and super specialties. Whatever topic you want to talk about, we can go to any number, as I said. We should plan for every day in our calendar one CME at Woodlands. And I would like actually every institution to be like that way, because those journeys, that excellence journeys, are the studies, the innovation, the academics actually will push us to do even better work, even better things, even better serving to our patients, to our community. So I will urge each one of you to take up your own areas of academics, whatever way you want to do some research. Right now, of course, our sizes are less, so there's less space in the hospital. But I would urge all of you to kind of keep working at it, so that it's once the project really starts, another month to go, they'll start digging. And it will very soon, the construction will be over. The 3 years will just go off. So we will be, out of our breath if we don't start right away. And we have started. I think we have enough time. Just please plan. Please come over to Malti or Dr. Shaptoshi or, our marketing team. Or me, anyone, communicate to us. We will immediately organize and do the CMEs, and we will keep meeting. I think this is what is necessary, and we will continue to do so. So thank you once again for all of you for being here, and I'll not take many of your time, and we'll go ahead with the next session.
Thank you so much, madam, for motivating us. Please don't go away. I would request Dr. Malti Purkai to please, our Chief Operating Officer, to please come up to the stage to felicitate our madam with a bouquet of flower. Shreya will be assisting. Thank you, madam, for motivating us and always supporting us in these endeavors. So without further delay, we start our first session, heart failure, medical therapy, optimization and device therapy. And I will be there in the center right away. So I am in the center, and in my left and my right, I have so much of knowledge and experience. I mean, I'm a bit nervous. Anyways, I don't need to introduce this person who's sitting to my extreme right. Dr. Shunil Borun Roy has been immensely associated with us and doing a lot of cases, and he is the director of cardiology at Woodlands Hospital. Among the finest cardiologists in the city, Dr. Roy is known for his skills as interventional cardiologist and excellent patient care. A big round of applause for Dr. Roy. To my extreme left, Dr. Saroj Mondol is a practicing cardiologist with experience of 20 years, and he is experienced, skilled, and awarded doctor in his field of specialization, has extensive experience in cardiac imaging, cardiac catheterization, and he has published about 100 articles as original article, review, article, and contribution of chapter in books. Please, a big round of applause for Dr. Saroj Mondol. To my immediate right is Dr. Imran Ahmed, my senior of Calcutta National Medical College, and is a senior interventional cardiologist in the city. He is associate professor in cardiology at Medical College Hospital. He is an academician and multiple foreign fellowships. He has done multiple national, international publication. His area of interest is coronary artery intervention, mainly through radial route, pacemakers, CRTs, and congenital disease. He has over 20 years of experience in cardiology. A big round of applause for Dr. Imran Ahmed. And to my immediate left is Dr. Hema Malti Rath. So she is been practicing over 2 decades in cardiological interventions, including devices. She performs coronary angiography, coronary angioplasty, pacemakers, ICDs, CRTDs, congenital heart disease interventions like ASD, VSD, PDA. He has also managed large-sized coronary care unit for almost 14 years. Dr. Rath has been actively involved in public education programs and has delivered health talks. A big round of applause for our only lady cardiologist, Dr. Hema Malti Rath. So, just to hear from all these experts, I start off with this very interesting topic of heart failure, medical therapy optimization, and device therapy. Now, my first question to Dr. Imran Ahmed: how do you define or classify heart failure?
Good evening, everybody, and our host for the evening shouldn't get a bit nervous because he's at least under safe heart. So
exactly.
We'll take care of his heart. And the good thing is that you're going to ask questions, isn't it?
Yeah.
You needn't answer them. So I think the first question which we are going to, I think he's asked is very relevant. How do we define heart failure? So in very common terms, and which we have already been taught at our graduation level, is that it is a complex clinical syndrome which is resulting from the failure of the heart to either relax or eject out blood. So it's just not ejection problem, the problem is also in relaxation, and that we also know as the diastolic heart failure. So it's not only systolic heart failure, it's also diastolic heart failure, a combination of two. Now, once you need to classify it, I think there's something on class, and there's something called stage. Stage probably we'll discuss, since you've asked the class or classification. It would be a functional classification, what we do know as the New York Heart Association classifications, NYHA, class 1, 2, 3, and 4. So class 2 would be symptoms which are coming on ordinary exercise. Suppose you're going 2 flights stairs up and you get breathless or have chest pain or palpitations. So that's class 2. So an exertion more than that, and then you're getting symptoms, class 1, or less than ordinary exertion, that is just 1 flight of stairs. Having a bath, that is, you're getting symptoms of heart failure, that's class 3. And symptoms at rest or on minimal exertion, that is just buttoning, unbuttoning your shirts, that is class 4, and that's dangerous. So that's how you classify. The other aspect would be to classify the problem, or the approach would be whether the patient is wet or dry, or whether the patient is hypotensive, that is cold or warm. So that is also another way of classifying and managing. So a wet and cold patients. Wet means there is congestion, and cold means there is hypoperfusion. So clinically we can see by the blood pressure, if it's low, if there is decreased urine output, so that means it is a patient with this which has hypoperfusion. That means the patient is cold. It's cold. And if the patient has good perfusion, that's warm. And again, wet means you have crepitations, you have neck veins engorged, you have hepatomegaly. That means there is congestion. So wet and cold patient is bad. So this is how you classify the patient.
That is very nicely explained. Thank you, Dr. Imran. Now, my next question to Dr. Hema. What are the stages of heart failure?
Yes. After just Imran discussed about what exactly heart failure is and why does it occur due to systolic and diastolic function of it if it gets impaired. So after knowing that, you have to stratify the treatment part. So to treat the patient, you got to know which stage the patient belongs to. So to know the stages, the AHA guidelines which we usually have read from our childhood is stage. There are 4 stages in which the symptoms of the heart failure patients present to us, and got to identify each stage and treat accordingly to the stage and the presentation of the patient. So as I told you, there are 4 stages. It's divided as stage A, B, C, and D. So what is stage A? Stage A is those patients who are at risk of getting a heart failure. They don't have any symptoms, but they have all the risk factors which can precipitate a heart failure, like diabetes, hypertension, obesity, and underlying coronary artery disease. So how do you treat this stage A patients is by treating the risk factors, not exactly the disease modifying drugs causing heart failure. Now stage B, what are the patients coming under this? Stage B is they have a structural heart disease, but they do not have signs and symptoms of heart failure. So they already are patients who have had a MI, having a regional wall motion abnormality, or a patients who are hypertensive, as I told you, having an LVH causing a structural heart disease, or an asymptomatic valvular heart disease. So how do you treat these patients? So these patients are supposed to be treated with the precipitating cause, like coronary artery disease, we are treating it along with it, and the other valvular heart disease, we treat the cause and then prevent the heart failure. And in patients who having less than 40% ejection fraction in the stage B, they go into the treatment of the 4 pillars of heart failure. Those are the number 1 being the ARNI, the SGLT2 inhibitors, beta blockers, and the MRAs. So these patients who are having stage B having a less than 40% ejection fraction can fall into this group. Otherwise, treating the cause can itself prevent the heart failure. So which is stage C then? Stage C are those patients who already have signs and symptoms of heart failure along with the structural heart disease. They can be at failure during your presentation or suffered a heart failure earlier. So these patients are very dangerous. Stage C patients are the one who has to be monitored very carefully. So they should be seen whether they will be needing a decongestive therapy so that it doesn't cause a worsening heart failure, which is a newer concept in spite of the adequate GDMT management. So now, apart from this, stage D are those patients who are refractory to all the treatments. They need special interventions. They are symptomatic at rest. So apart from the GDMTs and the 4 pillars of heart failure, they need special devices like LV assist device and heart transplant or another CRTDs and an ICD to prevent the sudden cardiac deaths. So these are the 4 stages, which is very important to know the treatment protocol for every patient presenting to you in your OPDs or in the inpatients.
I mean, very nicely described in short by Dr. Hema Malati Rath. I mean, thank you so much. A lot to read and lot, but you have simplified it and expressed it in a very nice manner. Thank you, Dr. Rath. Now my question to the Director of Cardiology, Dr. S.B. Roy. Guidelines of heart failure, and with your experience, sir, how do you look at it? Do you follow the guidelines? The experience you have treated the heart failure, how do you combine your experience with the guideline?
Always we have to follow the guidelines. Guidelines made long back by American Heart Association. So as long as we are practicing from the beginning, we are always following the guidelines. Guidelines are made by different studies, and those studies are on large scale combined double-blind studies, and it has been shown that it is beneficial for the patient. So always we have to follow the guidelines, and in guidelines in heart failure, in asymptomatic patient with myocardial infarction, those are totally asymptomatic. In those group, always you have to treat those group of patients with ACE inhibitor. If ACE inhibitor cannot be tolerated, then ARNI, not ARNI, rather ARBs, that is one medicine that we have to give within 24 hours after infarction. And always you have to keep in mind, as per guidelines has given that we have to give that medicine. But there always we see the condition of the patient. Guidelines it is a broad spectrum, but each and every individual, every patient is different. If somebody is hypotensive, we cannot follow the guidelines. When guidelines has been given, then you have given ACE inhibitor in doses, but guideline doses may not be tolerated. Then in that case, we have to reduce the dose to keep the blood pressure, to maintain the systemic perfusion adequate. If in that doses adjustment is very, very crucial. In that case, it is the role of the primary treating cardiologist or physician, they should decide. Guidelines will instruct us, but implication will be done by the cardiologist or treating physician. That is regarding ACE inhibitor. Then beta blocker. Beta blocker we have to give at the earliest. If there is no contraindication, we have to start with metoprolol or other beta blocker which has been tested, means either bisoprolol or carvedilol in myocardial infarction. Then statin. In each and every group, statin is a must. We have to give statin from the beginning. And other indication means if patient is in volume overload means failure, then diuretics, and subsequently if any arrhythmias are there, we have to treat arrhythmias accordingly. So we have to follow the guidelines correctly, and we have to treat the patient accordingly.
Thank you, sir. I mean, this is what we've been listening to you. Really nice. I mean, your experience, and you've seen so many guidelines being updated over the years. Thank you, sir, for your expert comments. Now, my question to Dr. Saroj Mondol. Propose the sequencing strategy of heart failure medication.
Good evening, doctors and my friends. In continuation with Dr. S.B. Rai's statement, we have 3 guidelines in the entire world that we follow in our cardiology guideline. One is CCS, Canadian Cardiovascular Society guideline. Second, that was last came for heart failure in 2017. And ESC guideline, that European Society of Cardiology guideline, that came around 2021. And AHA, that means American Heart Association, or ACC, American College of Cardiology, that came in the 2021. Though that guideline, we definitely follow guideline because they have vast experience, as already mentioned by Dr. Rai. Now, regarding that medication, which should be started first and which should be started last, that again depends on the certain situations like patients' age, patient's blood pressure, patient's renal status, that potassium level, pulse rate, and blood pressure. Usually, if everything is good, then and acceptable, then we start with the ACE inhibitor or ARB. Now, then after ACE inhibitor, ARB, then we start beta blocker, then MRA, mineralocorticoid receptor antagonist. Then we give usually that SGLT2 inhibitors, and then ARNI. But regarding, again, the different, these guidelines, among these guidelines, then when to start ARNI, either initially when the ARNI came in 2016, through the ESC, that in the conference itself I was there, that they initially told that ARNI, the IC inhibitor should be started fast, then gradually taper off, and after 4 weeks that ARNI should be started. But now all guidelines, they have the consensus that ARNI can be started from the very beginning. Now that again, what I was initially telling, that everything depends on that patient's blood pressure, whether it is giving support or not, whether patient's heart rate is giving support or not, whether potassium level is high, then before starting ARNI or MRA, we should start SGLT2 inhibitors. So in this way, that every patient should be individualized, that's already mentioned by Dr. S.B. Rai. We should not stick, we follow guideline, but we will not stick to the guideline. Every case is different. So according to, we will start that, we do the sequencing of the drug. Again, another question is how much drug, the titration, whether we should give the maximum dose initially, or over the how much period we will maximize the drug. Now, we should, that all consensus, according to 3 guidelines, they say that initially 50% of the drugs, that total maximum tolerable dose, we start in the beginning, and over next 10 to 16 weeks, or as early as possible, that initially they were telling that after 16 weeks you can titrate. Now they are saying that within 10 weeks we should maximize the drug maximum tolerated doses.
So in continuation to the question, I would ask Dr. Hema regarding how to titrate the medications in heart failure.
Yes. As Sarojda told, the guidelines are to be followed as per, because it is the latest, depends on multiple randomized controlled trials where they have studied the patients, but they are all not in the Indian subset. They are all for the European population and other countries. So here, still we, in the recent 2023 ESCA guidelines, we have, there is change in titration of the dosage of the medicines, the 4 fundamental drugs which I mentioned to you in the treatment of heart failure, that is the ARNI, SGLT and beta blockers along with the MRAs. So what I want to say is, if titration was initially thought it has to be sequential. You start 2 drugs, then you follow him up, again start 2 drugs. So the sequential titration of the drugs was an earlier concept before the recent 2023 guidelines was supported by a strong trial like strong heart failure. So they have studied more than 1,000 patients of these heart failure, and they found titration it should be rapid. That is what they say. But Indian patients, we got to slow down. For example, in hospital patients, we get many of the acute heart failure patients. The first thing is we decongest it. Decongestion is the class 1 indication. They use the loop diuretics, decongest the patient. Then you assess the patient whether he has got into euvolemia. That is, after that, you kind of, along with the decongestion, you start all the 4 drugs if in a minimal dose where the patients can tolerate along with the situation of the patient, depending on his blood pressure, urine output, serum creatinine, potassium, and other features. You start with the minimal dose and how many hours he can tolerate. So after he is stabilized, then how do you titrate? Should I discharge him with the minimal dose or should I do what? So generally it is before anticipated 2 days of discharge, you try to give at least half the dose of whatever the drugs mentioned by us repeatedly to early follow-up. So the recent guidelines or recent practices escalate the drug within 6 weeks to the maximum dose, which is not so in the Indian status because it is the tolerance and the associated comorbidities are very high. So you got to increase as per the protocol, it has to be followed up also with the different blood tests like NT-proBNPs, serum creatinine, and then serial echocardiographies for the ejection fraction and mainly signs and symptoms. Those have to be followed every first week, second week, third week, and then about 6 weeks he has to get into the maximum tolerated dose and be stable. Otherwise, he can be continued with the minimal dose or the reduced dose of the prescribed fundamental 4 drugs for the heart failure.
Very nicely explained, Dr. Hema. Thank you so much for explaining in such a lucid manner. My question to Dr. Imran Ahmed, carvedilol, bisoprolol, nebivolol. What is the favorable beta blocker in your practice and what are the advantages and the disadvantages over each other?
So I think this hospital has been there for more than 70 years now, Woodlands. And across the time when medicines for heart failure was coming in one by one, there was a period during our MBBS time and following that where beta blocker was downgraded. But for the last 15 years or so, with evidences available, beta blocker is one of the most important pillar of heart failure therapy. Because, as we know, there is receptor change in the myocardium as the heart failure progresses. Initially, it's a favorable response, but ultimately it acts against the heart. And it causes LV remodeling, which is harmful for the heart, and the heart starts enlarging and the failure keeps on moving. So we need to block this beta-1 receptor, the increase which is occurring. And for these receptor blockers, we need the beta blockers which are highly selective. Like, as you mentioned carvedilol, you mentioned, I think, bisoprolol, nebivolol. But I think guideline-directed treatment, if we are talking about, and we have to agree on this platform, as experts, what we have to say is that the treatment has to be guideline-directed. And in the guideline itself, they have mentioned what are the conditions where any of the 4 pillars which Hema was speaking might not be used, because there are indications, contraindications, that's a part. But you have to start early, because all the mechanisms have to be hit hard. It's the cancer which keeps on progressing. The more the patient gets hospitalized, the earlier is the next hospitalization, and the earlier is the death. So 50% after hospitalization will die in the next 10 years. That's the higher mortality rate for heart failure. Now, among the beta blockers which you asked, so the guideline directed would be carvedilol, bisoprolol, as well as metoprolol. Bisoprolol, in my opinion, is 150 times more potent than metoprolol, which is easily available. So we have a trade-off between easily available, cheaper molecule metoprolol and a potent molecule if you can follow up. In a situation in Woodlands, we'll keep on following, the patient will attend. So in that case, I think bisoprolol is a better choice. Regarding the starting dose, it depends on the blood pressure, the heart rate, especially with beta blockers. So if they are on the lower side usually, then in that case you start with lowest dose, which is bisoprolol 1.25. The ACC has set 1.25 twice daily. Now, bisoprolol is an OD medicine, but 1.25 twice daily if you're starting 1.25. Otherwise, once you start with 2.5 or you go on to increasing it, you can go to 7.5. That's OD. And metoprolol, of course, start with 12.5 or 25 OD and then go on to, you can even go on to 200, but it's not required in the Indian setting. And carvedilol also, the 3.125 BD, you can go to high dose as 12.5 BD. Nebivolol, as such, has a greater hypotensive effect. As cardiologists in heart failure, we are not comfortable with nebivolol because we don't have an RCT with it, randomized controlled trial in heart failure with nebivolol. I think.
Yeah. So, in continuation to this, what Dr. Imran Ahmed said, a very pertinent question to you, sir, Dr. S.B. Roy. Short-term titration versus long-term titration. Which one do you prefer in your practice?
Just before talking on this topic, on beta blocker, Dr. Ahmed has nicely explained everything. For our knowledge, two more molecules, particularly carvedilol, in COPD patients. If patient is having COPD, in those group of patients, carvedilol is not a good choice. In their bisoprolol and metoprolol, those two molecules has been shown in different studies is better than carvedilol. So it is our knowledge, for our knowledge, we should know that carvedilol we should not use in COPD patients, as we are having better options. And carvedilol is having one side effect, it is having alpha blocker. So with carvedilol, already in MI patient or heart failure patient, drop in blood pressure, there is a possibility. And we clinicians should titrate accordingly. As we are having choice, Dr. Imran Ahmed mentioned, so bisoprolol and metoprolol, long-acting one, succinate, that will be better choice. Now, regarding titration of medication, Dr. Hema already mentioned how to titrate, but our aim is in long run. This heart failure patient is not one day problem, 2 days problem, months problem, it is year problem. Yes, so our aim should be to titrate in long run, but during titration, initially, when we will be starting medication, there will be ups and downs in blood pressure and symptoms. So initially we should titrate with short-acting medicine if possible, or long-acting in lower dosage as Dr. Imran Ahmed already mentioned. Bisoprolol 1.25 once, and if patient can tolerate, we can give it twice. And gradually you have to titrate over time, not in short duration. Weekly you have to see. And in hospitalized patient, it is not possible to keep the patient for long run. At the same time, in OPD patient, also it is not possible to come so frequently. We have to make them understand, and it is the general physician who is looking after. That physician is very, very important to titrate the medicine. We have to write in prescription and to make them understand that how to titrate and how frequently. And our main guide is the blood pressure and heart rate. Blood pressure and heart rate, and particularly in beta blockers. And titration in ACE inhibitor. ACE inhibitor, if we start ACE inhibitor, there will be a chance that there will be a change in potassium level as well as renal function. Those who have compromised renal function, in those group, we have to start in lower dose and we have to keep an watch, particularly in rise in potassium level. Those two things we have to keep in mind. And one more thing I want to mention, in acute MI patient, in heart failure patient, ARNI we are using so frequently, but in acute MI, ARNI is not indicated. That we have to keep in mind. Then our physicians, so many people, as this is a good medicine and consultants are writing, everybody is writing, but we have to keep in mind that ARNI we should not use in acute MI subset. In this subset, ACE inhibitor is better one, and it has been shown in studies that ANI is not helpful in acute MI. It is ACE inhibitor is always better. And in titration for all medicines, beta blocker, ACE inhibitor, slowly over time, over weeks or months, we have to titrate. And as per guidelines, all patients may not tolerate the guideline-directed doses. In those group of patients, to keep the blood pressure, means perfusion pressure, it is in cardiology, hemodynamics is the most important thing. We have to keep the blood pressure systolic at least more than 110. If it is coming down, then there will be deterioration in renal function because of low perfusion pressure. So titration is very important. Hemodynamics, particularly blood pressure and heart rate, these two things you have to always keep in mind, as well as other symptomatic status. Means giving medicine, patient may feel that weakness. That weakness, always you have to keep in mind whether that weakness is due to low perfusion or due to beta blocker, which medicine or side effect of the medicine which is causing that side effect. So in heart failure patient, we have to keep always watch on the side effect as well as the effect on the medicine. And I think a good clinician always look into in this aspect. We have to treat the symptom, and at the same time we have to keep on working whether we are giving medicine creating new symptom and discomfort to the patient. So titration should be gradual, and our aim should be in the long run.
Thank you, sir. I mean, very important points made by Dr. S.B. Roy with his experience. Very shortly, I would like to ask Dr. Saroj Mondol the role of ivabradine in low ejection fraction heart failure. Shortly.
Say that ivabradine, idea behind giving ivabradine is that we know that we have to control heart rate during that heart failure. Because the tachycardia itself can cause deterioration of the LV function, that is known as tachycardiomyopathy. That patient, particularly who is not patient with low ejection fraction, heart failure, they usually have low blood pressure, so it is very difficult for them to start with beta blocker. So in that cases, we start that ivabradine in those patients to control the heart rate. And all three guidelines that the CCS, ESC and AHA, and also with our experience that a patient who have that ejection fraction less than 40%, and also who has the heart rate more than 77 or 80, we should start with them with that ivabradine. Also, apart from that low ejection fraction, even the patient with that preserved ejection fraction, we can give this ivabradine, because low heart rate is important both in diastolic heart failure and also systolic heart failure. In systolic means that in that preserved ejection fraction, there is a problem with that diastolic filling. So with the low heart rate, the filling will be better, so the function will be better. So in that both respect, it is more useful in that reduced ejection fraction. It is also useful in the preserved ejection fraction.
Thank you. Role of iron therapy in heart failure, Dr. Imran.
So you should have more iron, isn't it, to make you strong?
Yes.
So I think the point here is just a point on ivabradine. Now, I think those who are well versed with these guidelines, 2023, this latest this coronary stable angina guidelines in ACC, they have given a class 3 recommendation for ivabradine. That means you cannot use harmful if the patient does not have, those with angina, stable angina, and those who do not have LV dysfunction, less than EF 50%, they have given a class 3 indication. So this is one thing which we need to explore. This is something just come, and we were discussing in medical college. One of the trainees was presenting it. So that's one point. The other point here is, but then again, heart failure you can give it. So in heart failure, ivabradine over and above beta blocker can be given. And the question you asked is iron therapy. The short answer to you, we will not go into the mechanisms why anemia need to be seen in heart failure, because symptoms increase. If the iron is less, the oxygen delivery to tissues decrease, and therefore what you get is more symptoms. because it's over and above the cardiac output, which is less in heart failure. If the oxygen delivery is also less because of this hemoglobin abnormality, because less iron, you get this. So anemia needs to be treated. You need to see the ferritin stored. So less than 100, I think it's milligram is the unit, and then you need to give the iron. Or if it's between 100 and 300 ferritin, and the transferrin saturation is less than 20%, in that case you need to give ferric carboxy maltose. That's the approved drug molecule, IV, in a single dose of 750 milligram BD, 2 doses, but it's ideally 750 milligram to 1 gram. That's IV, that's the molecule which can be given.
My question to Dr. Hema, how long to continue medications after improved EF, post-treatment of heart failure?
Yes, this is a very important common question which arises in all the minds. While the patient, if you see a patient, you have started the drugs with the ejection fraction of 40 and he comes to you with an echo report of normal ejection fraction. Now you think, what should I do? Should I continue the drugs or I just stop? So as the mechanism, if you understand the neurohormonal modulation and sympathetic activity, it is there as subclinical heart failure, which is always there with, in patients who have improved heart failure if they find some precipitating cause. So at least you have to continue 1 year after the proper improvement in the ejection fraction in those patients who are having non-coronary or non-precipitating cause of heart failure. But again, there are no concrete studies to say that they can stop or you can titrate or down titrate the treatment. It's always better to continue because they have seen many consciousness trials and small studies which shows it relapses with just a precipitating cause. So what I mentioned to you as worsening heart failure, so anything which precipitates even on GDMT, you have to increase another 1 year of treatment for him to reassess for, and depending on the comorbidities what he has, to continue the heart failure medicine. As far as I know, I think they have to continue all 4 for a longer period of time. So that's one in between one worsening heart failure which you can come across in normal ejection fraction, that is improved ejection fraction, which they precipitate with any kind of medical problems like pneumonia or any other. That time you have a scope to add even a newer drug called Versugat. Versugat is that drug which can be added along with this. So there is, if looking into all these matters, there is no definite time period that you have to stop the medications after he has improved the ejection fraction. So you got to at least continue 1 to 2 years even after a proper improved ejection fractions, and then quantify or individualize the treatment depending on his comorbidities.
Thank you so much. Dr. Roy, I would like to ask you, what is the role of device therapy in heart failure, in short?
Device therapy in heart failure, that is in particularly when ejection fraction is less than 35% and there is a white QRS complex. White QRS complex more than 160, and if ejection fraction is less than 35, in those group of patient and ECG showing LVBB pattern, if we put device therapy, means biventricular pacing, that is very, very essential, very, very important, and it will definitely help. And in those group of patients, ventricular myocardium should be normal. Ejection fraction may be low, but myocardium should be normal. It should be viable myocardium. It is an infarcted myocardium. In those group of patients, response will not be good. And at the same time, if QRS duration in ECG, LBB is there, but if it is 120 to 150 in that range, non-responder will be more in that group. So even in those group, then we have to take the other evidence from the echocardiography. If there is dysynchrony in septum and posterior wall, and this dysynchrony is more than 130 seconds, in those group of patients also, they will help with biventricular pacing.
Thank you, sir. To Dr. Sharoj Mondol, the different ICD therapies, that is the CRT, CRTP, CRDDB, and CRTT, when to use in short?
So, in conclusion with Dr. S.B. Ray's statement that we have some guideline when to start, which is the patient we should give ICD, which is the patient we should give CRTP or CRTD. The one thing is very important that guideline and directed medical therapy should be continued for 6 weeks to 6 months before this decision of these ICD or CRTP or CRTD therapy. First. Second, if that whether CRTP or CRTD or ICD, that QRS complex demarcates that between ICD and CRTD, CRTP. Now, which are the candidates for ICD? That patient with that MI or that low ejection fraction, who has not, MI patient who has not received any sorts of revascularization therapy like CABG or PTCA, if they cross the 6 weeks from that index event of that MI and ejection fraction is less than 40%, they should receive, and they have narrow QRS complex, they should receive ICD therapy as a primary prevention of sudden cardiac death. And if this patient undergone PTCA or that CABG and they have passed 90 days, means 3 months, still they have the ejection fraction of that less than 40%, they should receive ICD therapy as a primary prevention of sudden cardiac death. Now, regarding the CRTP or CRTD, there are 3-4 groups of patients. Patient with ejection fraction less than 35%, as already mentioned by Dr. S.B. Rai, and LBB duration is more than 150 milliseconds, they should have the class 1 criteria to receive CRTP or CRTD. And if that these same criteria, and if the LBB pattern and duration of the QRS is 120 to 149 milliseconds, they are class 2B indication, class 2A indication. And that RBB with QRS more than 150 milliseconds, then they also have the class 2A indication. And a patient who has the fitting the criteria of ICD therapy, as earlier I mentioned, and if we assume that their pulse will be dependent on their ICD therapy, more than 40% of their entire pulse, they should receive CRTP or CRTD therapy. Now, who are the candidates for CRTP or CRTD? Now, there are long debates, and in debates, entire world, that debates still going on. The ischemic cardiomyopathy versus dilated cardiomyopathy. Who are the candidates will be that CRTP or CRTD? Now, they have given the simple logic that this DCM patient, means non-ischemic cardiomyopathy patient, they improve their pump function by around 6 months with CRTP therapy. Now, why they will then they should not receive then CRTP therapy? Now, insurance they put a question to insurance. During these 6 months, if the patient dies due to arrhythmia, that VT or VF, they will be responsible. Then the solution came, the patient who have the criteria to receive CRTP therapy, they ideally should receive CRTD therapy. There is no single criteria for CRTP therapy. That means the CRTP means that simple triple chamber pacing, the LV pacing, and CRTD means that CRTP plus ICD therapy. This is the basic concept, and this should be...
So thank you so much. These discussions will continue and continue, and there is a second topic also awaiting. Thank you so much, doctors. I mean, you all have been powerhouse of knowledge and sharing your experience and the current guidelines and updates. Thank you so much, everyone. I would request our MD and CEO, madam, to please come up the stage and felicitate our esteemed panelist of cardiologists. Please, madam, if you can come up. Woodlands Heart Association. Well, that's a very nice proposal from madam. So I would request Shreya to please help felicitate our panelist Madam will be felicitating Dr. Sharoj Mondol. A big round of applause. So now Dr. Hema Maltirat, Madam will be felicitating her. Very nicely explained. To the Director of Cardiology, Dr. S.B. Roy, thank you, Madam. And last but not the least, Dr. Imran Ahmed. Thank you so much for being here. Thank you, Madam. Thank you, everyone. So we move on directly to the second session of the evening, AI in coronary artery disease. I would request Dr. Chanchal Kumar Kundu and Dr. Abhishek Shaha to please take the dais. So the second topic, my first question to Dr. Abhishek Shaha. Application of artificial intelligence in cardiology.
Hello. Artificial intelligence has come off like a fire nowadays, and it is being tried in all the fields as well as in our field of cardiology, as well as in almost all the medical subsets. And particularly in cardiology, being so much of instruments we use, so artificial intelligence is being tried in almost all the aspects, starting from imaging, from basic ECGs, as well as during our different nuclear cardiology, as well as during interventions. So a wide spectrum has opened, and trials are going all over the world, and the future will tell how much man will do by himself and how much the robots will do.
Dr. Chanchal Kumar Kundu, artificial intelligence in ECG.
Hello. Good evening, everybody. Respected doctors and my dear colleagues and dignitaries. Artificial intelligence is a new topic to us. Most of the things are theoretical as of now. So its application has to come a long way. So in cardiology specifically, it has been many application more rather than less, but in other medical field, amongst medical field, cardiology has many application in artificial intelligence, especially in interventional cardiology. So in ECG, right now what is artificial intelligence? It's machine learning, and another component is deep learning. So many data and electronic health records are given input, and they get some pattern, and they do logistic regression analysis and give us input. So it's a pattern recognition, face recognition, image recognition. This comes a long way, and they give input in a precise way, in accurate way. So human, in that level, that human brain and a person cannot think. So in ECGs, think, and a 65 years old male patient comes in emergency with a stroke, ischemic severe, and or a OPD. So we start antihypertensive, say mildly hypertensive, non-smoker. So we give treatment. Now the dilemma is when to start anticoagulation or not. You know that anticoagulation has its effect and side effect, bad effect. So why? Previously we called it cryptogenic stroke. You have heard of it, that embolic stroke of unknown origin or unknown source. So whether we need to start anticoagulation. So you need to recognize, is there any arrhythmia or not in ECG. In normal sinus ECG, we cannot find arrhythmia. Here's the application of artificial intelligence. They do the pattern recognition of subtle ECG changes that tells you he or she might have silent atrial fibrillation over the years, or by monitoring some smartwatch, Apple Watch, or IV core. So they can tell you up to 20 to 50% might have silent atrial fibrillation. And these patients need some anticoagulation, and they may benefit for recurrent stroke and may prevent further stroke. And this is the application that artificial intelligence can recognize silent or asymptomatic atrial fibrillation. They can recognize asymptomatic LV dysfunction by only seeing the ECG, not echo. Even the echo, ECG, some pattern recognition is there. They can tell you with 90% predictability that this person having ejection fraction of less than 35% without doing antiproBNP, without doing echo. This is the application of artificial intelligence. They can tell you the telltale sign of hyperkalemia without measuring the potassium level by seeing only the ECG. These are the application of artificial intelligence in near future.
Thank you so much. Very nicely described. Dr. Abhishek Shaha, echocardiography has been an age-old thing. I mean, many years it has been one of the main diagnostic modality. Now, after the invent of artificial intelligence, how do you see echocardiography change?
Well, artificial intelligence is also being tried in various, all the aspects of echocardiography, starting from basic 2D echocardiography to 3-dimensional to stress echo. In all the fields, artificial intelligence is being applied. And what they have come to with initial trials, that there is a high degree of detection of very minute problems, and they detect this very fast, much faster than what we humans can, even with years of experience, can do. So we get accurate diagnosis at a much lesser time in a busy OPD or a busy clinic where you have to do say 25, 30 echoes. You can complete the whole 30 echoes within say 1 hour. So, and there's very subtle changes which our even years of experience cannot detect. Artificial intelligence is being able to detect it with 90 to 95% accuracy.
So coronary angiography, Woodlands was one of the pioneers of starting coronary angiography in those days. Now with the advent of AI, how do you look into this coronary angiography?
First, we need to know who needs coronary angiography and why it should be needed. A patient coming to emergency department, like a 55 years ex-smoker coming with at midnight chest pain. Some ECG changes is there, STG changes. So how to know that is he or she need coronary angiography or not? There is the application of artificial intelligence. There is some machine learning which incorporate age, sex, their history, and coronary calcium score to say the pretest probability of obstructive coronary artery disease with more than 90-95% positive predictive value. So one application is pretest artificial intelligence in pretest probability, that who needs and who don't need. Those the intermediate risk patient, those who might or may not have coronary artery disease, they can tell you this patient with seeing the ECG and some pattern recognition and history that this patient might have more than 50% obstructive coronary artery lesion. And here's the application of artificial intelligence, and there is a coronary calcium score, all recognized, you all know that, with Aguston score. They can tell you the Aguston score without doing the CT, some genomic study and single nucleotide polymorphism study. And there is CT and coronary angiography, there is some intermediate lesion, that 40 to 90%, there is significant or not. That can be done by CT-FFR by artificial intelligence. CT-FFR is fractional flow result, which can be done by CT scan only, cardiac CT only. We don't require invasive angiography, we don't require FFR wire in the getting the patient admitted and doing in the cath lab. So CT-FFR can do and can reconstruct a three-dimensional image and can tell you the percentage of lesion with very precise and accurate way. This is the application of CT and angiography and application of AI in this.
Thank you so much, Dr. Kundu. Cardiovascular imaging as a whole, how do you look into the perspective of AI?
In cardiovascular imaging, I want to add a few points for echo. And there are several few trials are being done or have been completed where they have seen that even untrained persons, say nursing staff who have never done echo, can do a echo at bedside with the help of artificial intelligence. You put a probe on patient's chest, the machine will direct you tilt the probe to that angle, you will get a better picture. Say you get only a apical 4-chamber or 5-chamber view, the AI will reconstruct the whole heart in a 3D mode, which is say 90 to 95% close accurate as far as cardiac MRI. So artificial intelligence with an echo is for all practical purpose will compete with cardiac MRI in very near future. Coming to other imaging modalities, there are also say SPECT image or like that. In every field, it is being found that application of AI gives almost near accurate diagnosis in as far as an experienced radiologist or an experienced imaging expert in other imaging investigations also. So maybe we are facing a new era of imaging in cardiology as well as in intervention cardiology. Say by the next 10-15 years, things are going to change.
Thank you so much, Dr. Shah. Challenges in application of AI in healthcare. So if there are benefits, if there are improved modalities, there got to be challenges. How do you look at it?
Everything new comes with some challenge. It's good for our society. There's artificial intelligence making the human effort more efficient. There's less time consuming, more complex case can be done, etc., etc. But there is something, machine learning and deep learning, two parts of artificial intelligence. That's a very complex process. And there is something called black box. In the plane, there is a black box. The data cannot be integrated or interpreted properly because it uses some complex algorithm, artificial intelligence. So, and there is some data bias also. So, artificial intelligence uses data, electronic health record, mobile health record, and interpret its own way and give input. So, where comes from this data? This data comes from the hospital record, comes from the society, comes from the health clinic, but this have some bias. May not be applicable in generalized population. So they are giving input based on this data we have given to him. So it may not be actual representation. And patient information may be leaked. This is the main problem. There's some vital information may be leaked, and there is human touch is lost. It's a major issue. So you lack human touch in clinical field, and there is some problem. There's job. This human job will be lost. These are the main challenges of artificial intelligence.
So the last question of this topic, I would be asking both of you, 2 lines for each of you. How do you conclude this AI in cardiology? First, Dr. Shah, and then Dr. Kundu.
Well, as far as my opinion, I think we have to make friends with AI to survive and to serve.
So, AI has a bright future. I can tell you that lot of information we cannot remember. In application, we see the angiography, we see the echo report, some calculation, some valvular heart disease, there is some complex calculation, flow and area and all these things, which can be done easily by artificial intelligence. They can say that this lesion has to be addressed, this lesion can be left, that's coronary artery disease, can be left alone. This procedure, this complex bifurcation needs to be done, or it can be done by single stent in a complex lesion. That can be. So we are using our own, my knowledge, but artificial intelligence, there are a lot of data and lot of health record and lot of similar comparison between 2 groups. They are doing the analysis, and what is the best for you, they are giving you the best thing. So it has a good future in
So thank you so much for your comments and your views on AI in cardiology. In my right, it was Dr. Abhishek Shah. You all know him. So he has an experience of 19 years in this field, and is attached to SSKM Hospital and is a consultant cardiologist at Woodlands Hospital. So he's very academic, and wish him a bright future. To my left is Dr. Chanchal Kumar Kundu. He has multiple fellowships in cardiology and is a senior cardiologist in Arjikor Hospital, and he has special interest in pediatric cardiology, and he's a consultant cardiologist in Woodlands Hospital as well. Thank you so much for being with us. I would request Dr. Malti Purkait, our Chief Operating Officer, to please felicitate Dr. Shah and Dr. Kundu. Please. So after the felicitation, I would be going on to the questions. So Dr. Chanchal Kumar Kundu. And Dr. Abhishek Shah, felicitated by Dr. Malti Purkait. Thank you. So please take your seat. I will be going to the questions directly. So any questions from the first topic? Heart failure, it's medical management and device therapy. Any questions?
Yes, there's a question. Here. Yes.
Yeah, please.
Your
question to which doctor, if you can please?
Dr. S.B. Roy,
Right.
Dr. Sharoj Mondol, Irfan Ahmed.
Okay, please.
So the first question is the role of ivabradine in heart failure. When are you exactly placing it? A patient on beta blocker, the heart rate is not yet controlled, there you are adding, or a patient intolerant to beta blocker, there you are adding. That is the first question. And the second question is regarding heart failure. Where do you exactly place verisuagat? It is add-on to the 4 pillars, whether you will add on to the patient for the added benefit, or when the patient is intolerant to only their hyperkalemia, etc., there you are placing it. So if in detail that can
So the
be
first question to Dr. S.B. Roy, sir, please.
Role of ivabradine. Now, you have already given the answer that if
Dr. Chanchal Kundu and
heart
Abhishek,
rate
please.
is adequately controlled with beta blocker, then there is no role of ivabradine. If it cannot be controlled and adequate dose of beta blocker to control the heart rate patient cannot tolerate, in that case we usually initiate ivabradine. And in spite of beta blocker, if heart rate is more than 75, then you have to add ivabradine initially 5 milligram twice daily. If it is not controlled, then after 1 week you have to increase it 7.5 milligram twice daily. to keep the heart rate in between 60 plus minus 5, so that ventricular filling will be better and patient will be symptomatically better.
The second question to Dr. Sharoj Bundul.
Regarding verisuguat, you can go do add-on therapy, or you can start from the beginning. These few groups of patients, they get a tremendous benefit from verisuguat, particularly those who have renal failure. There is no contraindication. You know, the ARNI and ACE inhibitor is contraindicated in that patient with renal failure, but verisuguat we can give jolly well. That those patients can be given with the verisuguat.
Ivabradine in a condition where you can start before beta blocker is one condition where the heart rate is high, of course, but the BP is on the lower side. If the BP is between 90 to 100, then we have some inhibition in starting beta blockers. So therein you can start Ivabradine.
Versugat, it's actually an add-on therapy rather than the first-line therapy. It is like those patients who have completely on all 4 drugs and they're still going to worsening heart failure. There's a new concept now, which even after the optimal treatment with all the 4 drugs, if they go again requiring IV diuretics and get admitted, those are the ideal candidates you have to add Versugat. You can start from a low dose and go higher till the 10 mg. And the second set of patients are those who cannot tolerate this ARNI and they have an hyperkalemia and other renal compromises. The pharmacodynamics and kinetics of these drugs will help to add on and prevent the cardiovascular deaths in kind of heart failure patients. For eGFRs less than 15, these are safe.
So any more questions? We have a gentleman there.
So while treating heart failure, what should be the heart rate we should aim for? 75, 90, 100?
What is the heart rate we should aim for a patient of heart failure?
So I think the heart rate should be less than 70 and between 55 to 60 is good, because beyond less than 55, especially in elderly, the patient gets different symptoms of bradycardia. So 55 to 60 is a small, between 55 to max 70, it's good enough.
Thank you.
Please hand over the mic to doctor.
Thank you. It was a wonderful presentation, all of you, sir and madam. Now I want to know, according to latest ESC guideline 2023, where will you place SGLT2 inhibitor? To Dr.
I think since I've attended the Amsterdam conference, I can just tell you one thing. See, if you want SGLT2 inhibitor, across the board, that's the only molecule which is class 1 for preserved ejection fraction heart failure. That's there, that we know. In 2023, what has come in the ejection fraction in the mid-range, between 40 and 50% EF, that also is now become class 2A indication, SGLT2 inhibitors. So it's a wonderful molecule, and we need to use it frequently, and it is one of the main pillars of heart failure with either reduced ejection or preserved ejection fraction.
Thank you, sir.
Even in the mid-range ejection fraction, that is what is there in the newer guidelines in ESC. We know that it is class 1 both in reduced and preserved, but new guideline is you can start as a first-line drug, class 1, in improved ejection fraction.
Thank you.
We'll take one more question.
This question is directed to Dr. Abhishek Shah and Dr. Kundu. It is regarding the place of CT-FFR. So, where do you exactly place it? A patient is having chest pain with ECG changes. You want to send the patient first invasive angiogram. Before that, you want to do the CT-FFR to assess whether the patient really requires that interventional angiogram or not. What is the exact place? And what is the cost? And how regularly it is done?
CT-FFR, I can tell you, is a gatekeeper for the invasive angiogram. Yeah. If you do the CT-FFR, you got the lesion is not significant, you don't need to go for invasive angiogram. You got when? No, chest pain patient with intermediate probability of obstructive coronary artery disease. Obstructive means less than 50% lesion. They should be in emergency patient. Intermediate probability according to Birmingham risk score or ACBT risk score or TIMI risk score, Gray score, there is a lot of scoring system in cardiology. So you got the patient in chest pain, you have the ECG, you have trop T which is negative in 1 hour, or high sensitive trop T, negative. So, but patient having typical chest pain. So, and age is around 55 or 50 to 60, no family history of early cardiac death, or etc. This, you got the risk score, you got the ECG, you got the trop T, and you cannot decide whether to admit the patient or leave the patient. You get a CT, or can do a CAC score also, coronary artery calcium score also. If it is more than 100, is significant. 0 is not significant, and more than 400 is very, very high. So, and do a CT, and with machine learning or artificial intelligence, they can do a CT-FFR also with the CT angio. And if it is significant, more than 50% nation, they can tell you with 95% precision. So you don't need, if it is not significant, disease less than 50%, they can tell you. And this time, less time is needed, no minimal radiation is needed, no need to go for invasive angiogram.
So thank you. One last question, please.
My name is Dr. Samiran Paul, and my question is to Dr. Ahmed. Sir, we're discussing about SGLT inhibitors. Sometimes in our clinic we get the diabetic cardiac myopathy patient, and they are using for long time SGLT. And what we have seen that in usage of long time SGLT, there is a higher elevated clearance of the creatinine, and as the same time the UTI. So what can be the manageable situation in such patient?
See, we are, I think, in one of the webinars and all we have, they were endocrinologists, and they were discussing that cardiologists, probably they are using it here and there, everywhere, and they're not looking at the molecule's adverse effect, and they're using it. So when I entered, in my talk I said, there are much more dangerous molecules like lanoxin, digitalis, like ARBs, who are AC inhibitors, who are causing renal dysfunction, and beta blockers, of course, have more side effects.
Exactly.
With the kind of heart failure hospitalization benefits, with the kind of benefits in mortality also, with SGLT2, it's a molecule which we have to use across the board. Right in this dais I'm saying, we have to use SGLT2. Now the incidences of candidal, basically it's yeast infections you get because there's more glycosuria because it's a glucose-mediated water loss.
Right,
that
right,
SGLT2 does,
right.
and therefore you get benefits in heart failure because of the water loss. So this glucose can lead to infection, especially in females. So before starting SGLT2 in your prescription, just ask them whether they have had a history of UTI or not. If they have a history of UTI, then you need to follow it regularly and probably not give it. Suppose you have got and in the next visit, you have to remember in any patient you have started it, whether patient has symptoms of burning micturition or itching in the private areas. So then in that case, you need to stop it and maybe retry afterwards. But a simple advice to maintain proper hygiene, that does well because it's just mainly candidal infection which occurs in these cases.
Exactly.
As far as renal dysfunction, I don't think so happens. In fact, it halts the EGFR decrease, this drug. So, and it has direct mechanism in the kidney as well as in the heart. So therefore, I think both DAPA as well as EMPA have shown in CKD and to be also good, you know.
Thank you.
So
sir,
I think
sir, I have another question to Dr. Mondal. Sir, sometimes we have to use GTN and ranolazine for the stable angina patient. So in my clinical practice, I sometimes use GTN and ranolazine. So what can be the right advice, whether it is GTN for twice or the ranolazine for twice?
So I hardly ever use GTN. I always use ranolazine.
Okay.
My practice.
Thank you, sir.
So one last question by Dr. Soumitra Bhattacharya, our consultant radiologist, please.
Hello, good evening, everyone. And my question is to Professor Kundu. That you were speaking about CT-FFR. So that's a very interesting topic. And I chanced upon that I visited two big producer of high-end CT machines just within a couple of months. So I inquired about it, and in fact, I went to the research lab of one of such producers, and I talked to some research scholars, and actually they're the pioneer. So they said that there in India, they have got some strategic partnership with some IITs and so that now it is in cath lab, they are driving it, you are doing it, but CT-wise, it has not been yet standardized. So that is my first question. And the second question, it's a very interesting topic that you are talking about, the application of AI in detecting cardiac diseases. So a few months back, it's Sundar Pichai alphabet. He has said that by a simple retinal scan, we can diagnose the cardiovascular status of a person. Now, how enthusiastic you are about it? These are my two questions. Thank you, sir.
Thank you.
So the first question to be answered by Dr. Chonchol Kunu, the second by Dr. Abhishek Shah.
As of the CTFFR, I think I told you that in my topic that CTFFR, along with the artificial intelligence, that they can incorporate many data that normal person and those having lesion, they are comparing this data and taking input, and they doing the 3D reconstruction, vessels, complex lesion, and they are doing CTFFR with maximize the input, but you are talking that they are not able to.
Sir, what they are telling me, that's number one, it has not been established in clinical practice.
Yet to come.
Yeah.
Here the application of artificial intelligence in CTFFR. It's many topics they are in literature.
Actually, I went to there only to mainly to gather experience about artificial intelligence. There are some dual energy technologies like the sandwich technology that we are applying to characterize a plaque, whether it's fibroplatty or fibrocalcific, these natures.
Artificial intelligence also can tell you there is calcium containing or non-calcium containing.
Yeah, not calcium. Yeah.
And according to code this plaque and tell you there is a fat attenuation index is there.
Yeah, yes. Yeah.
That can be done only by artificial intelligence, not by human, or we can radiologist or sonologist cannot do it. That fat attenuation index can tell you this lesion is going to burst, that's plaque going to rupture. That can be done by artificial intelligence. So that is the application of artificial intelligence, but near future it will come. And in cath lab, there is integrated FFR. We are coming with some cath lab in SSKM and Arjikar.
Yeah, I know, sir, that you are doing it routinely. Yeah.
So thank you so much. I mean, all the cardiologists are here in the stage. I would request Madam, our CEO and MD Madam, to please come up for a group photo. Malti Madam, please, if you can come up. Dr. Shomitra Chatterjee, please come up. So we'll have a group photo, and after that there is a 5 minutes topic by Dr. Sharoj Mondol, IVUS in complex PCI. Thank you so much. So I would request Dr. Sharoj Mondol to come up for a short speech, IVUS in complex PCI.
We know that left mainstem coronary artery, during routine coronary angiography, we see that 5 to 8% of the patients have left mainstem coronary artery disease. And this mostly involved that 80% of the cases involved the distal part or bifurcation of that LMCA. The LMCA is something different from other coronary artery because it's a huge caliber of the artery. And second is it's that dimension starts from that 3.5 to 6.5 millimeter in diameter. So it often that stent we use have to have good expansion capacity. So that in most of the patient, we have persons have left mainstem have two branches. In 2/3 of the cases, that LAD and LCX, and 1/3 of the patient had another branch is that ramus intermediate artery. So that we know that left mainstem coronary artery in right dominant coronary system that gives supply to the 80% of the LV myocardium, And in left dominant system, almost 100% of the LV myocardium is supplied by the left main coronary artery. So there is very small marginal error should be acceptable during intervention of the left mainstem coronary artery. Now that again that left mainstem coronary artery also involves the other coronary arteries, and there are multiple comorbidities, so that intervention of the left coronary artery is risky. Now historically, CABG presented the treatment of choice in coronary artery disease because of long-term patency rate of that Lima graft. But and unprotected left mainstem, if we keep untreated, then there is 3 years mortality has been up to the 50%. So CABG has been regarded as the gold standard for the LMCA disease. Now with the advent of that PCI techniques and stent technology, along with adjuvant pharmacotherapy, we started to re-evaluate the role of PCI in LMCA disease. Now different trials have also shown that individual total mortality, cardiac death, stroke and MI were not different between the CABG and PCI. Only target vessel revascularization was little higher side in patient with PCI. Now, standing between the technical complexity of the PCI and proven efficacy of the CABG in LMCA disease, it is essential that when PCI, we address the LMCA with PCI, every effort is made to ensure that final outcome of revascularization is as good as that is potentially achievable by the CABG. And in this aspect, that we use our imaging technique, and that is IVAS, and that has come as a class 2 indication according to the standard guideline. Now we know that coronary artery is a two-dimensional picture, so you need to have see the inside regarding the vessel characteristics, regarding the calcification of the vessels, and regarding that size of the vessels. And IVAS is accurate technique for assessment of the both lumen and wall characteristics. Now before stenting, we need IVAS to see the stent size, to see the calcification, to make the strategy whether the calcification can be tackled by the simple balloon or that vessel modifying balloon or that IVL intravascular lithotripsy or rotablation. Just I am going to show a few cases done during the last few weeks, 4 or 5 cases. That is, you can appreciate that imaging technique and technical expert is also both essential. Next. This is the one patient I have done this Monday only around 6 p.m. The angiography is done. That you can appreciate the critical stenosis of the LMCA, almost subtotal occlusion, and extreme right. If you during injection to the right coronary artery, you can appreciate there is that retrograde flow to the left mainstem coronary branching. That means that this artery has got that critical LMCA stenosis, almost subtotal occlusion, or you can say total occlusion. So it is very difficult and when I asked our surgical colleague, they really refused at 7 p.m. They can't arrange that CABG and that so much of blood and that emergency CABG is not possible. And if you don't do this procedure, again the patient will die because of the critical LMCA lesion. LMCA supply, I have already mentioned that around 100% of the LV myocardium is supplied by the LMCA. Then with hard difficulty, we was able to cross the LMCA distal critical lesion, routine dilatation of the left mainstem coronary artery, the routine dilatation. Then LMCA midpart also was subtotal occlusion, so we dilate it. Then that midpart stented, then proximal area is stented, that post dilation or port. Then the final result. You see the left side, we had the coronary artery before starting the procedure, and this is the final result. This is a 47-year-old person with anterior LMI. You see that trifurcation lesion and that all ostium. We can see that we had to engage their coronary artery by the 2 catheter, the ping pong catheter, because with 1 catheter it's not possible to address the 3 vessels. So we we had addressed this artery with 3 simultaneous kissing stenting, the simultaneous kissing technique, and this is the end result. These are my mobile recorded video. You can appreciate that all 3 vessels are critical lesion. All 3 has equal that good caliber vessels, ramus intermedius, and in the circumflex and that LAD. We wire 3 vessels, dilate, stenting, 3 stenting, and this is the end result. This tripercussion stenting. This is done again probably 2 weeks back, this LMCA lesson. Anyway, there is severe calcification. We have done rota, then stenting, then recrossing, bifurcation stenting, rewiring, then again that this is known as tap technique. Different techniques are there in LMCA stenting. We use tap technique here, then simultaneous kissing technique. This is the end result. The mid part, I needed one stent. The end result was like this. This pot, again final kissing balloon inflation. This is the end result. Then again I was run that we needed to see the expansion and apposition of the stent. You can appreciate good expansion and apposition of stent. Again this IVAS guided that in the culotte technique we had utilized these vessels. Again these are the final kissing, the final pot. Then again that we have done IVAS, that expansion and apposition of the both stent was good. Even with the IVAS we don't need the final picture. Then this is on 32 years old male with this ejection fraction. All cases we had done during the ad hoc procedure during the angiography itself, because the surgical friend, they can appreciate that it's not possible for them also to address these vessels during that angiography itself. You can see there is critical stenosis of the LCX and proximal right coronary artery. Here we had used that T-stenting because of the angle between the LAD and that LCX was more than 90 degree. So recrossing would have been very difficult. Then again IVAS guided to see the expansion apposition. These are the probably 6th or 7th case. You see, you can appreciate with simple injection you can see that entire LMC ostium is not visible, and that lower down picture you can see that RC is giving the retrograde flow to the L6 ostium. Then again this I had used the reverse culotte technique, the standard technique. Now in my personal experience during 15 years of independent cardiology intervention, I have done maybe a few hundreds of cases of LMC every week we do. But till date, God's sake, I have not lost a single patient. We follow up. There are very rare 4 or 5 the restenosis. Otherwise, all patients are doing well with regular follow-up. Now, in conclusion, IVAS-guided LMC PCI have been found to be significantly reduced the all-cause mortality by 40%, cardiac death by 53%, plus reduce the risk of stent thrombosis and TLR. And in meta-analysis of 10-year study, they have shown that IVAS versus angiography, that IVAS had given the tremendous good result pre and post PCI as a part of their imaging procedure. And this is likely to be reduced by the proper stent size selection, placement, expansion, and apposition, and that result ultimately in the greater stent diameter. Thank you.
Thank you so much, Dr. Saroj Mondol. We have arrived at the final part of the program where I would like to invite Dr. Soumitra Chattopadhyay, Deputy Medical Superintendent, to say the vote of thanks. Thank you.
A very good evening to you, friends. This brings us to the end of today's Woodlands Cardiac Update. We have had 2 most informative sessions on heart failure, medical therapy optimization and device therapy, and AI in coronary artery disease, as well as the talk on IVAS in complex PCI. The interactive sessions were a clear indication of the pertinence of the topics. I'm sure we would continue to meet in our future CMEs of various disciplines and super specialities. On behalf of Woodlands Hospital, I would like to extend a formal note of thanks to our esteemed speakers. Dr. Sunil Baron Rai, Director, Interventional Cardiology, Dr. Saroj Mondol, Chief Senior Consultant, Interventional Cardiology, Dr. Imran Ahmed Siddiqui, Consultant, Interventional Cardiology, Dr. Hema Malti Roth, Consultant Interventional Cardiology, Dr. Abhishek Shaha, Consultant Interventional Cardiology, and Dr. Chanchol Kumar Kundu, Consultant Interventional Cardiology. I would also like to thank our Managing Director and CEO, Dr. Rupali Basu, for her presence, encouragement, and guidance. Thank you, ma'am. Dr. Malti Purkayat, Chief Operating Officer, Woodlands Hospital, for her guidance as well. And of course, Dr. Shaptoshi Basu, Medical Superintendent, Woodlands, for being the MC today and moderating all the academic sessions. Very good job done, Dr. Shaptoshi. Thank you. A big thank you to all our dear doctors in the audience, senior members of Woodlands Management and Team BDCR for successfully planning and executing the event. Last but not the least, a big thank you to our sponsors, Boston, Lupin, Pristin, and AdHealth. Thank you for your support in making Woodlands Cardiac Update a resounding success as well. Thank you so much for coming. Thank you.